called her and I said, so how much?
Good afternoon, everyone. We are about to start the meeting, so if you can come and take your seats. Thank you.
This is Governor Brian Kemp. I'm honored to address you for the inaugural meeting of the Healthcare Workforce Commission. When I signed the executive order creating this group, I knew it would play an important role in addressing the challenges we are facing in this essential field. Georgians in every corner of our state depend on a reliable, quality healthcare system. But the pandemic has taken a toll on its men and women who work in our hospitals, doctors' offices, and health clinics. We must act quickly and boldly to address the workforce shortages we're seeing in this field. That is why I've appointed each of you to this commission to thoroughly examine what we can do to improve the condition of Georgia's healthcare workforce. I look forward to hearing the solutions you propose to the challenges before us and to working with you to build a stronger healthcare workforce pipeline that benefits all Georgians. With your help, we will ensure that Georgia remains the best place to live, work, and raise our families. Have a great meeting, and God bless.
All right. Good afternoon, everyone. Thank you so much to Governor Brian Kemp for sending that inspiring message as we get started with our very first regular meeting of the Georgia Healthcare Workforce Commission. My name is Shawn Walker, and I am so pleased to be with you all today to facilitate today's discussion. Before we get started with the agenda and today's presentation, I want to first walk through some information on the format of this meeting, which we believe will be very helpful. First, commission members, the microphones at your table are hot and can pick up all sidebar conversations. So if you want to mute your mic at any time during this meeting, please press and hold that center button and your conversation will be muted. Second, this meeting is open to the public for observation. If any member of the public has questions or comments about the material we're covering today, please send an email to the Commission's inbox at hcwf.commission@dch.ga.gov. We routinely monitor this inbox, so we will respond to all emails as soon as possible. Thirdly, we have commission members attending in person, as you can see, and some also attending virtually. In a moment, I'll take an official roll call to determine which commission members we have in attendance for today's meeting. And lastly, today we are presenting to the commission on data collected around Georgia's healthcare workforce challenges. This is very interesting and it's a lot of information. So as the presenter moves through this information, he will pause at the end of each section to allow the commission members an opportunity to ask questions, make comments, and have dialogue. This is extremely welcomed. We are looking forward to this collaborative discussion amongst the commission members. We will closely monitor the time we allocate to each section because we do have a lot of information to cover. So if we feel that we're getting bogged down in one section, we will move along to the next section just to make sure we have ample opportunity to get through the entire presentation. And as an aside, we have invited our consultants, McKinsey, to assist us with answering questions related to the data. All right, so that's it with my talking points. I'll move into the roll call. Commission members, after I call your name, if you can indicate you are present, I'd really appreciate it. Scott Bolke.
Present.
Thank you, Scott. Mary Chapman. Mary Chapman. Debbie Dalton.
Present.
Sherry Danello.
Present.
Janae Dock.
Present.
Clark Hill.
Present.
Sean Little.
Present.
Kaylee Noggle. Sally Perry.
Present.
Pete Quinones.
Here.
Rick Roach.
Present.
Scott Steiner.
Here.
Tanya Sudia.
Present.
Jean Sumner.
Present.
And Courtney Terwilliger. Thank you. Chair Noggle, turn it over to you.
Thanks, Sean. It probably goes without saying, but none of this would happen without Sean Walker, the director of the Office of Project Management at the Department of Community Health. So thank you, Sean. She'll be a permanent fixture as part of this group. Thank you to all of you that joined us in person to come kind of watch the commission's proceedings, as well as all of you that we know are attending online, and we are taking note of those attendees online. Commission members, this feels very formal. And that's really just a byproduct of how we're trying to work to make it viewable to the public, but it's not intended to be. So please feel free to dialogue, ask questions, all different things today. I'm excited about today. I'm especially excited that we're on the campus of Mercer University. I have shared a great partnership with Mercer over the years in some of my former roles, and believe so passionately about the role that private educational institutions play in educating Georgians. So I want to thank them. I want to welcome President Underwood, who was kind enough to grace us today and to host us today and give him an opportunity to tout all things Mercer. But thank you, President Underwood.
Thank you, Commissioner. And it's a great privilege for me to welcome all of you to the Atlanta campus of the university. I especially want to thank you, Commissioner Noggle, for being here, and those of you who are serving on the commission. You're doing really important work. It's a significant charge you've been given by Governor Kemp to identify what our healthcare workforce needs are and what some of the solutions to those needs may be. Really important work. Our mission here at this university has been addressing healthcare needs for many decades now, and we're about that work, and we're eager to partner with you all in finding solutions to our healthcare needs. I'm pleased that Dr. Sumner, the Dean of our School of Medicine, is a member of the commission. She's been a transformational leader for us in medicine. The scope of her school's activities now range from Atlanta in the north to Valdosta in the south and Columbus in the west, all the way over to Savannah in the east. When I came here, we had 240 MD students, and by 2026, we'll have 720 MD students as an indication of the growth under her leadership. We're now operating a series of rural health clinics throughout the state. We've launched new residency programs in 3 municipal areas in Georgia, and all of that's important work. I'm especially pleased that her last entering class in the School of Medicine has half of its students from counties of 50,000 or fewer, where we have an acute need in the state. So we're pleased with that work. Many people don't realize we have a significant nursing school here in Atlanta. It has about 500 nursing students. We're looking to expand its operations into Middle Georgia where we have an acute crisis in access to nursing care. Our College of Pharmacy is here and has been here since 1903. We're building a new pharmacy building right next door to train the next generation of pharmacists. And then our College of Health Professions is preparing physical therapists and physician's assistants and clinical psychologists and public health professionals and soon to come occupational therapists as well. So we're very interested in your work and we're very committed to being a part of your solutions. Thanks for being here.
Does this work if I just stick this in here, Sean? I think so. Okay, so let's dive into today. We'll kind of jump into our agenda. Again, you all know we were tasked by Governor Kemp to kind of study and provide recommendations by December on ways that we can improve the retention, recruitment, and staffing in the healthcare industry in Georgia, and kind of how we can address sort of like this when the levees break on our healthcare industry, the staffing we've all been trying to keep at bay for the last couple of years, and that's kind of ever coming to us. So today we're going to dive a little deeper into our work plan, our timeline, and then kind of specific. We'll look at some of the specific objectives we have. We did our kickoff in July. Today we're really going to spend the bulk of our time talking about the challenge that we're facing in terms of data, what we're seeing in terms of the healthcare workforce demand. I know that we're all eager to talk about the solutions part of the problem and all of our ideas, but it's really important, I think, for us to quantify how big the challenge is, and especially across the different specific sectors and professions within the healthcare industry. So we're going to spend a good chunk of time today talking about what the data shows us in terms of healthcare. Next month, we're excited to be on the campus of Augusta University, where we'll continue our dialogue with an open public forum. At the end of today, we'll kind of invite opportunity for folks that wish to come make presentation or provide testimony to the commission. In September, that's at the end of September. In October, we may switch it up and go straight into a second public forum, depending on demand, or we may revert that back to our next kind of formal commission meeting. And that will be October, will be at Albany Tech. In November, we'll meet again in Savannah, and then we'll try to wrap up our work Monday in December back in Atlanta at the Capitol. We're hopeful for. So we have a lot to do in the next couple of months, but I'm confident that we can do it, especially with all of you and our partners. So today, really three main goals for today. We're going to look at expectations for today and what we hope to kind of agree upon when we're done, which is really how we kind of frame and focus our efforts. We'll engage in a kind of a review of the workforce fact base. Again, our data consultants were here with us to help kind of answer questions as we work to kind of understand the dynamics between both the demand and the supply from the pipeline standpoint. And then we'll kind of talk about, with the remaining time, Q&A, and where that leads us and where that leads you as commission members to want to dive further, either looking at other nuances within the challenge or where we start to focus our time, energy, and effort on the solution. So with that, I'm going to sit down and take my seat and introduce you to Brian Lipton, a senior policy advisor with the Department of Community Health, who's going to lead us through today's presentation. He'll stop after each of these sections of the presentation, and we can have some answer any questions that you have, or try to, or make some notes for conversation for follow-up later. So thank you all again. All right.
All right. Good afternoon, commission members. That's just a little bit. Can you all hear me? All right, perfect. Well, good afternoon, and thank you for having me here today. We have some great information to share, and I'm really looking forward to the discussion that we'll hear from you. So moving right in, we have used an organizing framework of healthcare occupations to understand Georgia's healthcare, our workforce and supply dynamics. We've used this framework as an organizing construct throughout the presentation for how to understand the workforce today. And we've organized the healthcare occupations into 7 categories up on this slide. Those categories are primary care, nursing care, behavioral health, pharmacy, dentistry, specialty care, and emergency medical services. Except for EMS, we've segmented each category into their primary providers and the corresponding allied healthcare occupations in each of those respective categories. The number in the wheel represents the number of occupations in each category, and the underlying data for each occupation comes from the Bureau of Labor Statistics and informs the insights throughout the rest of this presentation. So we'll move on to our next page. That first framework, that's kind of like our prologue to the presentation to understand kind of the framework and the construct behind how we're going to look at this. This is truly our agenda. We're going to look at the data from three perspectives. First, we'll look at the overall demand supply gap across categories of the workforce. We'll then look at the insights we can learn from the changing demand for care. And then last, we'll look at sources of supply that impact the availability or the number of available workers in Georgia's healthcare. So if we move into our next slide, starting with the demand supply gap, the single most important takeaway from today, I'm going to go ahead and spoil it up front. Healthcare demand is growing faster than the supply of healthcare practitioners across most professions. This is going to be due to population growth, an aging population, and an increase in disease rate, which is increasing demand, and then a limited graduation pipeline, higher attrition, and age-driven retirement that constrains supply. We have a shortage of healthcare workers in Georgia across most professions, and the share of unfilled roles has nearly doubled since 2020. And data insights from the surveys and interviews suggest that things could get worse over time without intervention. So moving into our next slide, the gap may grow as demand increases and supply does not keep up. Across categories, degree completions remain lower than the forecasted job growth, as all job categories are projected to grow, which could further exacerbate the gap between supply and demand. And so on this chart, our first column on the left is going to be the employment as of 2020. The second is the projected number of average job openings between 2020 and 2025. The third column will be the projected number of degree and certificate completions. And so then this last column at the end is going to be the projected gap. And as you can see, we have a projected gap or a positive projected gap in all but just one area on this slide, and that's going to be behavioral health. And behavioral health possesses some really interesting trends that likely means that this data does not represent our current reality. And that's because the forecasts are based on the Bureau of Labor Statistics. They're inherently conservative because they're based on historical trends leading up until the year that the data was derived, which was 2020. And so then in 2020, of course, we had the pandemic, and we've seen a significant increase in the demand for behavioral health and mental health services as a result of the pandemic, dealing with both the disease itself, but then also, the social distancing and the remote environment of working and learning from home. So the demand has increased during that time period. There's also been a shift kind of in our culture that there's less of a stigma on reaching out for behavioral health services, which further increases the per capita utilization of mental health resources. And then those areas in particular really lend themselves well to a remote environment. A remote appointment with a behavioral health professional is one of the best, the easiest functions of that environment. And so we've seen an increase there as well. So likely what we're seeing is that we have just not caught up to the significant increase in demand that we've seen over the last couple of years. And as you can see everywhere else, we're seeing pretty significant demands. Apologies, we can move on to the next slide. So one measure of access to care is how much of a state can be designated as a health profession shortage area, or an HSPA. And these are areas where the ratio of providers to population falls below a certain threshold set by the National Health Service Corps. Georgia currently has 243 HPSAs, and about 3.2 million Georgians live within these areas. Georgia would need approximately 680 more primary care practitioners to remove its HPSA designations. And as you can see, we have a comparison to some of our peer states. Doing a little bit better than Texas and Florida over there based on this measure, but very much in line with Arizona and Washington, and then some of our other peer states do have a lower number of those HPSAs in comparison to our state. On our next slide, we look at there were 292 new primary care physician openings in 2020. Of the 568 med school graduates that same year, historic trends suggest that roughly 200 of them will become primary care providers, leaving about a third of those job openings unmet. And we'll see that this area extends to other areas of primary care. So nurse practitioners, for example, completions represent less than half of the openings in 2020. And this challenge extends to allied professions, where the number of completions for medical assistants also represented less than 50% of the openings that year. So this data is consistent with what we're hearing from the commission. Primary care has been identified by many of you as a significant issue, given the downstream chronic implications of the statewide primary care shortage. And several commission members reported that primary care physicians were among the most challenging to recruit for. So we have a couple of quotes down here at the bottom and down here in this bottom right. As shown in multiple studies, a good core of primary care will be great for the overall health of the areas, as well as the most cost effective. So this has been one of the areas that you all have really identified as a need. And just while we're here, I do want to just say thank you to all the commissioner members for their time and participation in taking those surveys and being interviewed to give us these insights. Given your extensive healthcare experience and your knowledge, we've used many of those insights and quotes throughout this presentation, throughout this fact base. And as a data person myself, or a data nerd, the numbers on the page can tell a story, but they only tell part of a story. And seeing the industry leaders, you live this and you see it every day, and you have insights that we can't show up on the page. And you're able to see how this impacts patients, how this impacts your staffs. And so we just really appreciate your guidance and your leadership throughout this process. And what we'll see on the next page is that a lot of the quantitative data that we're looking at is in alignment with the qualitative responses that you provided us. You've identified that primary care and nursing are two areas of particular need, and all the data lines up to suggest that as well. So in 2020, as an example, there were 2,000 openings for licensed vocational nurses, but only 358 credential completions, suggesting that the demand supply gap in that area will continue to expand. So that's less than a quarter in that particular category. And we will continue to come back to primary care and nursing throughout this presentation. And with that, I'm going to pause here for just for your first initial reactions, your insights, what resonated most, if you have any questions or feedback before we move into the next section.
On that number 2,065 new openings for licensed vocational nurses, that's not total openings, that's new openings, or is that total openings in the state?
Yeah, it's total openings in the state.
I would guess that number is woefully short. I don't know where that came from, but
It came from the Bureau of Labor Statistics in 2020. Consistent with the other.
I don't know where they got it, but I mean, I've got to believe that that number could be for just some of our bigger healthcare systems in the state. That number alone could cover them, much less 100 hospitals. 100 hospitals, that's 20, average of 20 opening or nurse openings per hospital in the state. That is incredibly short.
Yes, sir. I think that's just one small category, but certainly we can look at that.
Those are not RNs, correct? Those are just.
No,
So they're what? I'm sorry, I didn't hear that. They're not RNs?
no, sir.
LPN.
No, just one particular subset of the
All right,
vocational
so
nurses.
I would retake that back. That could be right for LPNs. I wouldn't know.
Is there a reason we only included family practice physicians in the primary care bucket?
Says internal medicine and pediatrics are also primary care.
Oh, we have the different category for pediatrics. I believe.
I mean, I think most of the medical schools would consider pediatrics and general internal medicine as a primary care track, not just family medicine. I think the thing that sticks out to me the most so far is as you move down the tree, we have more of an issue with our allied health positions and then non-MD professionals and then MDs. And I think a lot of the work that we've done as a state and our universities is focused on physician training, which is important, but without the CNAs and the MAs and the LPNs who do the grunt work of healthcare, none of this matters without them. And if you look at the gaps are far greater when it comes to those categories.
Yes, sir. Are there any other comments that we would like to discuss at the moment? Hearing none, we will go ahead and look at our rising demand across healthcare. So we'll look at our demand portion. Demand for healthcare in the state is growing, and that's driven by population growth, aging, and Georgians' overall health. We have already discussed the population growth and aging, but diseases with significant care burden are also expected to rise and further increase healthcare utilization. And we can already observe increased demand via the uptick in job postings for relevant healthcare positions over the past 2 years. So while Georgia's aging population is likely driving the increased demand for healthcare, its population of 65-year-olds and older is growing faster than national average, which increases the per capita demand for healthcare services. So we can see on the far left that our overall population is growing at about 1% compared to the national average of 0.6%. And then the 65 or older population has been growing at about 4.2% in Georgia compared to the national average of 3.4%. And then on the far right, we have our population distribution by age category at both the national and the state level. And while our portion of those that are 65 or older is slightly lower than the national average, that is our fastest growing segment in this chart. And so we will likely catch up with the national average in the coming years. On our next slide, we show that with the exception of cardiovascular and respiratory diseases, most other diseases with significant care resource burdens are expected to rise and further increase demand. Any cardiovascular disease is already at the top of this list, and it's expected to be relatively flat with just a 1% decrease. And then the impacts of COVID could make it so that the disease burden is even higher than what we have estimated here on this page. So as the care requirements of chronic conditions increase over time, Georgia will experience higher demand for services across all levels, from preventative care to primary care to acute inpatient services. The following slide, we have our job posting trends. We can see that the markers of increasing demand in those job postings, which have increased over the past 5 years, although with the exception of a small 2021 dip, likely resulting from COVID. And we can see that the highest numbers on the page are in some of these areas that we previously discussed, with nursing care expected to grow by, or the job postings in nursing care growing by 51%, specialty care growing by 53%. Our next two slides show the average annual openings for our top 3 occupations in each of the categories from our framework. And then on our right are for forecasted job growth between 2020 and 2025. And there's a lot of data on this page. So there's really 2 key takeaways that we want to discuss here. First, demand is expected to continue to increase for over the next 3 years across most healthcare professions. And then second, please take note of the scale and growth in some of our highest demand, or in some of our positions that we've discussed through the qualitative comments, specifically in nursing care. You can see that in those top three categories, we have 20,000 openings, and those are all expected to see experience more growth over the coming years. And then in primary care providers, such as medical assistants, nurse practitioners, and physician assistants, NPs are forecasted to grow by over 32%, and PAs are forecasted to grow by over 21%. And then on our next page, we have the same breakdown for our other four categories. So we're showing behavioral health, dentistry, EMS, and pharmacy. And the forecast for the additional demand, there's a forecast for additional demand in every position except for the pharmacy aides down there at the bottom. And we'll have one more slide where I'll highlight nursing in particular. Nursing highlighted by your comments as a pain point is likely to see job growth across all of these roles. So there are a few drivers of demand worth highlighting, and these are these bullets over here on the right. First, nurses could see increased utilization and care responsibility as doctors and surgeons may not fully meet the growing demand for healthcare services. That unmet demand might be passed on to our nursing partners. And then second, our nurses are spending more time on non-clinical activities or moving over to non-clinical nursing careers altogether, such as hospital administrators, health policymakers. And while it's certainly beneficial to have their experience and expertise in those areas, it does further exacerbate the demand for bedside care. I'll pause here again for another, if there's any more questions or comments or additional feedback, if there's anything that our commission would like to discuss.
Just a question, in the demand growth under nursing, that doesn't include the LVNs in that section.
I'm sorry, which slide are we on?
The demand growth in the nursing care section, it doesn't include LVNs in that section, it's just registered.
Exactly. This table is going to show the top three occupations under each category. So that'll be just further down the list.
And then where are the nurse practitioners in that category?
I'm sorry?
Where are the nurse practitioners? And are they with registered nurses?
Yeah, they're in primary care. They're the fifth down the page.
Okay.
A number of ways I think that we can slice this data. And so if this is not, from y'all's perspective, what makes the most sense, I think it aligns with how the Bureau of Labor Statistics categorizes a lot of these professions. And so it was a pretty good starting place for us, but I think we certainly want your feedback on if this makes the most sense to y'all as the practitioners of how we should look at data and quantify sort of this demand. I think, my takeaway is there's more people in Georgia, they're older and they're sicker. And the gap there is growing in some of these professions. But I think nursing clearly jumps off the page to us as one of the most critical. But I also heard some comments regarding some of the other professions that nursing and even the lower level of nurse practitioner or CNAs and other allied health professions, that if those folks don't exist within a hospital setting, and that's not the only setting we're talking about here, but at least in that setting, then nothing else matters, right? Like the care can't be delivered. So, but not to say, Pete would love to hear, from your perspective as well. I mean, the gap on EMS is much smaller on paper, but probably no more acute for you in the field, right? So we'd love to kind of hear, and same Sally within the BH world, maybe not as big from a numbers perspective, but probably no less acute for those of you that are living that every day. So would love to hear just thoughts on how we start to, and whether or not we have to, right? Like there could be some solutions that we ultimately talk about that apply across the spectrum. But if there are things that are specific or need to be catered to certain sectors of the workforce, is this the right way to look at it? How do we just keep those differences in mind, and what those credentialing requirements are, what the licensing and regulatory requirements are for those different things? But we'd love to hear your feedback on this is the right way to kind of look at these professions.
This is Sean Little, if I may ask a question.
Yes, absolutely.
Hi. So in reference, and I had put it in the chat, but I'm not sure if we're monitoring that. In reference to the defined difference between nursing assistants and personal care aides, depending on the data points, where you're collecting it, who's collecting it, sometimes those terminologies or specific job titles may come in different forms. So I've heard PCTs, CNAs, care techs, nursing assistants, and so on and so forth. Are we defining each of those roles out, or are we putting them into a broad category? Because that was a pretty big difference on the slide that you had there. And if that's showing as the number one for personal care techs, is that encompassing of CNAs? Is that including MAs? I mean, there's a broad category there with a lot of defined job titles, again, depending on where you're getting the data collection and how they're defining those roles. So are we defining them specifically within this context?
We're defining them according to the Bureau of Labor Statistics, and they do have those differences across those categories. So I think there's the specificity, excuse me, that you were looking for rather than the broad based.
Okay, so then when they're saying personal care aides, they're defining nursing assistants as like certified nursing assistants.
Correct. Yes, ma'am.
Okay, thank you.
I think the other thing to keep in mind, especially from our lens, is that this data is almost 2 years old, right? Like this is the most recent data that is wide scale across the state. I think that's where we'll look to y'all to bring to the forefront through interviews and your questionnaires, as well as some of the public forums that we'll have to hear from others, the specific issues that have really come to a head over the last few years. We've talked about, I don't know where Scott is, but around contract staffing and the challenges that has brought, as well as the emergence of behavioral health is such an emergent category. And so some things that the data is not going to reflect that I think is then on us to make sure that we hear and incorporate that more qualitative viewpoint until the data is reported, until we can share it. But certainly don't want to lose sight of some of those things that just kind of cropped up. So.
Does anyone else on the Zoom call have any questions? The chat is not currently being monitored so that we can ask your questions. So if you have any questions, if you can raise them now.
Yes, Scott Bulkey here. Family practice in small town Georgia. A couple of things. One, on your disease burden, I think you need to put obesity as a huge thing that we're seeing in Georgia. I think that overarches your diabetes, your cardiovascular disease. So I think we need to be monitoring that. What we're also seeing is cirrhosis of the liver developing from fatty liver. So I think that's a huge thing. Two is, I know you're getting your statistics from the Bureau of Labor, but the Georgia, I sit on the healthcare workforce board, and they have their own statistics about a lot of this too as well. And I wonder if we could perhaps incorporate some of their statistics into this too as well. So I'd love to see a little mesh of that too, because they're already monitoring a lot of this. And then thirdly is, I'd love to see nursing shortage, RNs, LPNs, a lot of them become nurse practitioners. And I'd love to see the statistic of how long does it take from a nurse to get to a nurse practitioner, because we're losing those people in the hospitals and the offices because they become nurse practitioners. And so I'd love to see how that is being monitored and checked, because I think that's a huge issue when it comes to the nursing shortage. Thank you.
And I'm just kind of curious why on slide 17 we're including massage therapists. Not that they're not important, but I don't know if I would put them in the same realm as medical assistants, lab technicians, MRI technicians, ultrasound technicians. It's just different. It's kind of nice to have, not an absolute. I have to have that. So I was just kind of curious why that was added.
Certainly. So we actually just have the top three by total number of volume in each category, and that just happens to be the number of, I guess it's one of the top three in that category. And then thank you for your comments. And we do just want to say that, a lot of the data that we have here, this is just a launching off point, and we do recognize that there's, a number of other data sources, and certainly wanted your feedback and commentary as to where you would suggest us, looking and where we can go and get some of those data points and, what you are interested in seeing. So thank you for all those comments, and we'll certainly take them back with us. All right. We can move into the supply section. We'll look at the healthcare workforce supply constraints and how some of the sources of talent are contributing to or taking away from Georgia's available workforce. So on this slide here, we have 3 key takeaways. First, the graduation pipeline is stable but not keeping up with multiple professions' demand growth. Hence, the pipeline is insufficient to fill openings for new growth and retirements. Second, a diverse group of public and private institutions support the training of the workforce, with nearly 50% of the healthcare graduates coming from the top 20 institutions. And third, beyond seats, our qualitative findings suggest the future workforce is further constrained by other factors such as staff shortages, costs, and access. In going through this next section, we'll emphasize the state of supply as it's affected by inflows to the state workforce, which are driven by migration into our state and by increasing volume of healthcare graduates and credential. And then the outflows from the workforce driven by retirements and those that are migrating from the state and to others. Although there is a talent shortage, Georgia's healthcare workforce is growing, attracting a net positive influx of talent from across the state and retaining most of its own graduates. So sitting here at the top of this waterfall chart, we have approximately 380,000 healthcare workforce workers today. We have our total outflow from the state, about 16,000 leaving the state of Georgia, but then another 18,000 coming in. We have, just basically because of some rounding on the page, it's a net gain of about 1,400 positions between migration in and out. And then we have an additional 12,810 healthcare graduates from local institutions. And so the net result of our 2 inflows and our 1 outflow is about 14,000 additional healthcare jobs in 2020. And then over on the right, we have our breakdown by category. On our next slide, although impending retirements are a challenge broadly across the U.S., Georgia is actually set up a little bit better than our national health, average. Our workforce overall skews younger compared to the national figures, which could be an opportunity to keep the existing workforce engaged and productive longer. Nonetheless, retirement should still be an issue in Georgia, but the effects might be a little bit less here than they are, throughout the rest of the country. Specifically on retirement-driven outflows from the healthcare workforce, 26% of nurses, 22% of behavioral health professionals, and 21% of specialty care workers are 55 years or older and are likely to retire in the next decade. And their current replacement rate, driven by degree completions and certificate completions, is not high enough to sustain and meet that demand. In terms of our workforce outflows from attrition, I'm sorry, can we go to the next slide? Yep. In terms of our workforce outflows from attrition, Georgia retains 58% of its healthcare graduates, which is about average compared to our regional peers. Texas has the best retention rate of 74%, while Virginia has the lowest at about 42%. And as shown on the right, categories with some of the needs, more acute needs that we've discussed here today, such as nursing care, primary care, and specialty care, are at the low end of this or about average compared to our total workforce. On our next slide, we have some education data. Health professions are the top field of study across Georgia institutions, but certificate completions are declining and degree completions are flat. So our degree completions are that bottom chart in the middle, and they're growing. They've grown by about 1% in total annual completions, while certificates conferred have actually declined by 4% over by the same period here. And then on the left, we do have our breakdown of all the total top fields of study, and you can see that health professions are the number one, or the number one category here in Georgia. On our next slide, we have We show that the top 20 Georgia institutions are producing about half of all completions. Moderate and incremental capacity increases in these institutions can have a sizable effect on the total annual workforce development. And commission members have called out private colleges as a positive contributor to fields like nursing. Private colleges were perceived to have strong student support and enable success for non-traditional student profiles. Finally, commission members are, your input, has been, there's really put an emphasis on the importance and the critical role of educational institutions in addressing our shortage. Commission members speak about the importance of addressing the supply shortage and highlight the need to improve access to healthcare education and training, increase capacity and reduce costs, and reassess the high level of requirements and certification needed to enter the healthcare field. We have a number of quotes to address each of those issues on this slide. Those are all the data points that we have prepared to present to you here today, but really looking forward to hearing your comments and your discussion.
On the healthcare workforce numbers in Georgia, I think it's slide 22. And looking at the employment, how it works, were in those categories, like if you look at nursing care or specialty care, were there any large increases in one particular profession, maybe that could have skewed those numbers a little bit? Did you see that in the day? Like if I'm looking at nursing care and, let's say nursing assistants was low, but nurses were high, then it would make that number look like, okay.
Certainly.
Just think about access to education and all those things.
I think that's likely a question they're going to have to take back and further analyze just to take a second look at.
What data is not here that would be helpful to our conversations and next steps? And does this feel like it's an accurate representation, especially when you start to look at the critical shortages across those kind of big 6 buckets? Do you feel like it's an accurate representation of what you're living and seeing and hearing? Are there other things that you would want us to kind of go back and take a look at and certainly hear from others, over the next couple of meetings, but are there some other things or other ways you would want us to go back and take a look at it?
I think we've got, I'm sorry.
This is Mary Chapman from Wellstar. I did have a question about the sort of macro category of nursing. Nursing at the macro is so broad. And when we look at each of our different entities, I think that our needs probably have a lot of variation. But we oftentimes think of them in large buckets as, acute care, critical care, emergency department, surgery. Wondering if we could, have a different slice, so probably a little more granularity in terms of the different lanes in nursing.
Absolutely. That's certainly something that we can take another look at. And hi, Dr. Chapman. Good to hear from you.
Hello, how are you?
I think one of my concerns is the issue with COVID. I think a lot of the data that we're looking at is 2020 data. And I think any of us that sit on the front line will tell you that the situation in 2019, 2020 is not at all the same as it is now. There's been so many things that have changed the dynamic for delivery of healthcare, in that, we used to have home health care, hospice agencies beating down the door for admissions. And for the first time in my career of 20 years, I have patients who cannot get home health care. They cannot get hospice care. They cannot get any sort of transition, if you will, from the acute care environment because they're so short-staffed with aides and particularly case managers, RNs, and things like that. They just can't take the admission. I think the other thing that's changed that, I mean, I'd heard of it, but not to the degree that we do now. I mean, we've lost some of our best talent to travel nursing, where I don't think that's going to be reflected here in the outflow of talent. I think we've got to figure out exactly how COVID has forever changed the way people look at working in general. I know in our area, in Commerce, where I serve as the mayor, we have an unemployment rate under 2%, but the home health agency locally can't hire a nurse. So how is that the unemployment rate's so low, but there's this void, and where have the workers gone? I think that's what we got to figure out is, are people leaving nursing? Are people doing these travel nurse programs? Are they working out of state now? But I think we just got to figure out exactly how COVID has affected us. And I think that's going to be a long-term effect. People have found new ways to work. They work from home. And people are just not in the workforce that were there before.
And I would have to amplify what he said around travel nursing. I don't know if those numbers are included in those that have left our state, but somehow we have to get our arms around that so that we understand what the need really is moving forward.
And so I might ask maybe, I mean, I recognize that many of you are just, there are front lines. And from my perspective, from a state perspective, contract and travel nursing really saved us during COVID. Like we would not have made it, I don't think, as a state without some reliance on that early on. So, and I don't know between now and December if we can solve the whole problem, but maybe the conversation is fine-tuned a little bit to how do we begin to unwind that reliance a little bit? Like, is there a way to start to just unravel that? Whether or not we can solve the whole thing, I don't know. But recognizing the critical role that particular piece of the healthcare industry probably will always play, but maybe how we start to dial that back. And would welcome that conversation and ideas around that kind of when we get to that point. But I think your point's very valid, right? Like, I think, yes. And I think that's where your interviews and the data that you guys can share with us offline one-on-one really becomes important so that we can layer those personal experiences and those hospital perspective and your provider perspectives over this data set to update it with what current reality is, as well as when we invite some public comment from the associations and others that can also speak to the totality of kind of the challenge we're facing. And again, I think I would ask and really want to hear feedback on this of when we look at nursing and the different, the granularity, and certainly from an educational credentialing and licensing, certainly very attuned to some of the nuances there, but in terms of what kind of, if you think about our end game as a commission, putting out a report with recommendations, where do those distinctions become most important? Is it in the granularity of the different types of nursing, or is it between nursing, allied health, physicians? What level of granularity? And we may not need to solve that answer today. We may just need to be aware of those differences as we start to talk about solutions and then figure out how we apply those solutions to which different components. And I don't really know the answer to that. I'm just kind of pontificating out loud at the moment, but we'll welcome other thoughts on that.
Are you referring to breaking down particularly nursing, RN, LPN, or particularly RNs? But, you know, what I was taking from your comment was there may not be a shortage in, I'm making this up, but critical care nursing, but there may be a significant shortage in nurses who provide behavioral health care or some other.
I would start with not making nursing one big bucket, but to break up the types of nursing, because they all have different practice settings, they all have different educational requirements, and I would start there divided up among those not home health aid. What does that really mean? Not licensed vocational nurses. What does that really mean? Not registered nurses, but what does that really mean? Is it nurse practitioners? Is it critical care nurses? Is it emergency department? Where is it?
This is Sean Little. If I may ask a question as well.
Of course.
Please.
Sorry, I'm not there, guys. So in reference to the supply assessment, which the area that we're looking at right now, I do think it would be nice to have the data surrounding the travel nurse component of it. Not so much, I mean, the numbers are good as well, but looking at a dive into why are nurses choosing that? Because it is not necessarily always the money aspect of it. So I would like to kind of see data along those lines. And then if there's a way to get that. And then also looking at overall COVID impact, not just to the providers, but also to the schools. There was a huge impact to nursing schools, which will impact the pipeline for the next couple years. The graduates that are coming out, the COVID graduates that are coming out are not, they did not have the same experience as non-COVID graduates. And I do think that needs to be part of some of what we accomplish here as well, is to address those questions and how to support that part of the pipeline, because that is going to be a significant impact to our healthcare within the state. So I know we're talking about supply assessment, but I do believe that needs to be part of the assessment.
One additional data point that I would like to see from the academic side, I know, of course, in speaking for nursing, the faculty shortage that we're experiencing in the state, and so some data points about faculty vacancies, projected vacancies, not just for nursing, but allied health and our other professions as well. I think that will help better inform this discussion.
That's a really good point.
And I'd like to add to what Dr. Steele and Bofi said, that really defining what you're talking about with primary care, because the state board does define as multiple categories, and what do you define as specialty care? An internist, family medicine, an OB, a pediatrician, all really are often categorized as primary care, but are they considered in your specialty care group? No, we need to know what you're talking about.
We can certainly provide, each of the occupations that we have in each category. And
Can we get, everybody talks about debt for physicians when they go to medical school, but we don't talk about nursing debt, what they have. So I'd like to see with nurses and other technicians, what kind of debt that they have too, and that might impact whether they even want to go in to get educated to become those technicians that we need.
Sure.
And I wouldn't mind also seeing where those graduates are ending up, where they're taking jobs, if that's possible as well within the state. And, everything seems to be so Atlanta centric, but it'd be nice to see them kind of move out to other parts of the state as well too. Is anybody going out there? Or are you making incentives for them to go out there to other areas of Georgia?
Yeah, Deb, I'm sorry, Deb, this is Scott Bulkey. Some of that's in the Georgia Healthcare Workforce Board data, so you could see it there. It's actually online. And that includes physicians as well as nurses and a few others. Number one. Number two, I'd love to see, actually, we all talk about recruiting. What about retainment? I thought part of this is also retaining folks. The ones that have been out there, and I'm a little self-serving here because I've been out there for 24, 25 years, is how are we doing to keep people in the areas that are needed? We can recruit all we want, but with the great quote unquote resignation that's been going on in the United States as well as all parts of the world, is that's going to be a very important. I just saw a statistic that twice April of this year, more people have quit than they of last year. So it's an interesting phenomenon. Once again, I'm all for recruiting, but also I think we need to add the retainment piece into this too. Thank you.
certainly, and we do have this one slide that's going to show the retainment statewide, but we can certainly look at drilling down into some more specific data and presenting that information.
Does anybody remember the Healthcare Workforce Board presented to us at our kickoff? And I don't have that presentation in front of me, but was their most recent year of data also 2020?
Yes, it is. But their 2021 data should be coming out pretty shortly here too as well.
Yep.
It's very, I have to say, it's very sophisticated. It's on their website. You can actually look at it on their website too as well. They've done a wonderful job of doing that and continue to do that.
I don't know if this is something the commission wants to look at, but I think there's a huge maldistribution of workforce, particularly physicians and nurses, and looking at geographic areas where there's really no healthcare and no workforce, and do a more geographic look at data if we could.
See, on slide 22, slide 22 almost makes you think we don't have a problem,
Yeah.
right? If we got 14,000 now, again, it doesn't necessarily show them in a different category or different buckets of nurses versus others. But if that was the only slide that somebody looked at, they'd wonder why we were meeting. Am I reading that wrong?
So
I was thinking the same thing.
Yeah.
So I will say that this does not include retirements. And I think another important takeaway is that even if we have positive growth, we're not growing at the rate that we need to keep up with even our current demands, let alone our growing demands. And so even though we have some positive growth, in order to keep up with the demand, it needs to be much higher.
Like to see a drill down for EMS. We really don't know how many medics are on ambulances, how many are in clinics, how many are in hospitals, jails, et cetera, et cetera. It's such a diverse field right now, the certification, especially post-COVID. So that would be something that would be interesting to see how many are really out there when you dial 911 that are responding and transport capability.
I would echo that. There's huge problem transferring patients to the higher level of care that they need. We just are waiting hours and hours, sometimes days, to get people moved from one facility to another to get the care that they really need. So that's definitely an issue. The other thing maybe if we could look at is the impact of violence on healthcare workers. There's been a lot of that in the news, a little bit in Georgia, a lot in other states too, but it's definitely, we're definitely feeling it in the ERs.
So EMS issue. I also like, when I was doing this a while back, the technical colleges did most of the training. There's very robust training program, phenomenal. And over the years, that has improved considerably. To the point now, over half of the EMS people are trained by private organizations. Many of those individuals are trained by the local government agencies that part-time instructors in this sort of thing, with varying degrees of success. It's interesting to actually get hard data on how many people are trained outside the technical schools and what is the success rate as far as they start with 100 students, how many do they test out and how many of those actually become licensed. That would be a good piece of information. The other piece, I think somebody might get on this, I think the reason I'm here is the rural courts will have a huge issue about being able to have EMS capable or accessible to take people to special care centers. On the trauma commission, that's one of our big issues. How do you get critical trauma patient from a rural hospital to a level 1 or level 2 center in a timely manner? And that's a problem.
Are there other sets of data that I mean, we are, obviously from my role and our staff role, I mean, Department of Community Health does not have direct access to all this data. We'll certainly call one of our colleagues at the Healthcare Workforce Board, but are there other sets of data where you guys know that we should tap into to assimilate that data into or on top of this? Or is that one of the things that we need to talk about, that there's not a single source of truth in the state over the healthcare workforce industry, or is there some recommendation that we need to consider to come up with that? Are we lacking the pieces in order to make recommendations? And again, I think I'll go back to what level of data do we need to really understand? Certainly in the long term, a lot more, but in the short term, between our current finite role and our task between now and December to get to some practical solutions, what level of granularity do we need to get to so that we can then make good recommendations?
Can we, I mean, I know we've done a lot of talking about the problems. I mean, we're tasked in a short amount of time with coming up with solutions. For me, I think the low hanging fruit, well, I know that most people who go to medical school don't get any kind of scholarship at all. And graduates are getting out with hundreds of thousands of dollars of debt. I don't know what that's like for a nursing student or whatever, but it looks like the low hanging fruit for me, as we look at solutions, is our technical college system. And I would like to know, I want to understand better how we currently fund the education of all these nursing, all these allied health professionals as well.
That I can talk
EMTs.
about all day.
Okay, well, I don't have a good,
Yeah.
as a commissioner, I don't have a good understanding of how that's funded, but also what does our technical college system look like? Do all of those locations offer nursing and allied health training? Do we have hot spots in the state? I know one of the commissioners mentioned about we need to be regionalizing this and not just saying, well, statewide, we don't have a shortage of this, we do have a shortage of that. Well, if we can focus on those community college type settings with the technical colleges, that's a way we could attack the problem, and knowing how it's funded, where the resources are. One thing I do want to talk about that we've not done a lot of talking about, again, I'm talking a lot about the post-acute care setting, because that's kind of what I do, nursing home and hospice and that kind of thing. In nursing homes, understanding how nursing homes are funded, and cost reports, I understand a little bit about it, but some of the homes that I work in are funded on cost reports from 2012 until 2019, and the cost of doing business is quite different. So it becomes difficult for them to continue to raise salaries or whatever. So I want to understand, I guess, how that works, but
Sure.
I guess on a broader scale, the regionalization of shortages, but also I don't know how we're going to offer solutions if we don't understand what the system is right now. Like
So let's talk about next meeting a little bit, because I think you're headed down at least where I'm headed. So TCSG, maybe it makes the most sense for us to, as a commission, to invite them to come talk about what they're doing at our next meeting, and to provide maybe some information between now and then on what their landscape looks like in terms of what their healthcare industry offerings, credentials are, and at which campuses, and whether or not they have sort of a strategic roadmap to help fill in some of this gap and the role that they play. I can tell you from a statewide perspective, allied health is one of the, I think, 18 career fields where a student that's eligible can go and get a free technical college certificate or diploma. So, and allied health is very broad within their categories. So there is free tuition available to students that want to enter into this field. Same with, we can spend, a lot of time talking about our dual enrollment students and how that kind of bridge works, and whether or not there's opportunity to expand kind of how we recruit and build out those pipelines. But maybe having TCSG come to the next meeting and talk to you about what that looks like.
And don't they work in partnership with I know we have one that just opened in Jackson County, the College Career Academies, as a bridge to, how many of those exist in the state?
Brian, do you know?
I don't know the number off the top of my head.
Probably, I don't want to guess, but certainly we can find that out. Are there others that you would like? I mean, that kind of brings us to how you want to use the next meeting, and or if you want to have an interim kind of offline conversations of, if there's groups of you that want to spin off into some subcommittees and do some work as well. I certainly don't want to drive the whole thing from my seat, but if there are some of you that you want to break off and to research some of these issues and bring it back to the group, I think that would be helpful in terms of moving the work along, given our condensed time frame. As we get into our next meeting next month, and and inviting public comment, we're certainly interested in hearing from the public who want to come and provide information, and we'll, essentially invite anyone that's interested to email us at the DCH's website of what that looks like. Unsure yet, depending on demand of how many, how long, all the things, but are there folks that the commission would like to invite to make a presentation that you want to hear from? Is it the licensing board? Is it TCSG? Is it someone from USG? Are there places where you know something that's working really well and it's someone that you want to make sure that we extend an invitation to? So we certainly want to hear back from all of you on that.
Can we invite Pam Clayton from the Georgia Healthcare Association?
Well, going back to your comment about data or missing data, I think we're probably all in agreement that the fact that the data we have is 2020, we all know is not representative of what we're seeing. And that, is it fair to assume that what we see now is then in 2020 is probably significantly worse? So I know, especially for behavioral health, in 2020, I don't think I ever saw programs closed because of staffing, and we see it all the time now. So should we just go with that premise that the shortages are worse than even what we're looking at here?
Yeah, if I could tag on to what both of them just said, thinking of what he said with the schools and the programs that are being offered at technical colleges and where we are regionally and things like that. And then what you just said about the difference in how we were. A lot of this data is based on how we traditionally staffed and the demand that we traditionally have. If you think about things we've had to do and how creative we've had to get over the last couple of years, redesigning care and doing things differently in order to care for the patient, this picture may look very different than what it did then, but it could also give us focus. If redesign is something we really focus on for allied health and have had a huge increase in the need of, whether that's aides or techs so they can get into the home health setting or post-acute care setting, or behavioral health, which previously may not have been in 2019 and 2020 may not have been as big of a need as it is now. Does that help us focus better if we look at where we are today and how we practice and what we need to grow and where we need to be? If we could get that data a little bit more finite, or have some of the schools come to talk to us, things like that. So I don't think, I think redesign is something we'll have to continue to try to do as we move forward, knowing that the workforce shortage is where it is and it's not gonna miraculously turn around. What do we need to focus on for that for the future?
I think this is a good roadmap to save time too.
No one's going to negate that, right? That's worse.
Commissioner, this is Mary Chapman again.
Hey, Mary, go ahead.
I wanted to mention, I think, and you may have mentioned, I think if we think forward, perhaps, 2 to 5 years, I know some of us are beginning to talk about what a digital operating model would look like, which really does also, again, change sort of the definition of what a nurse does. So I think of, telehealth and telemedicine, home care at home, and in, people's homes. I don't know the group, but I'm wondering if there is a group or an entity that would have some expertise in what's currently happening in the state from a digital perspective.
The Southeastern Telehealth Resource Center, which is a federally funded resource center, is based in Waycross, and they're over the entire Southeast and the Virgin Islands and Puerto Rico as well. So they could tell us that in terms of, because they're federally funded to do that, if that's interesting.
And if I could, Dr. Ryan Brashears is on the call, but he can't unmute, and he had a couple of comments, if I could share those.
Please.
He's the lead for our psychiatry department, our service line, and he states that some of the data might be a little off too. So the data that you had didn't account for the fact that 40% of psychiatrists only take cash and don't take insurance. So sometimes that data might be lost. 59% of psychiatrists are age 55 plus. So they are a bit older. So we need to consider them retiring. And think your data said that we only had like 22% of our behavioral health workforce is aging out. So he thought that was much higher. And then with regards to proportionality, when we don't have enough behavioral health providers in the areas, then it becomes more of a demand on primary care as well too. So we don't take that into account. Those patients usually take a lot more time to sit down and talk to them through their issues, not like just dealing with certain medical issues. So something to consider as well.
Thank you for those comments.
Sure.
Can I ask where those other sources of data are?
I'll,
And
I'll ask him and I'll.
Yeah, just so we
Sure.
can add to the list.
Okay.
Thank you.
Commissioner, you asked if we thought the data was lacking, and should we move towards a single source or a better set of data? And I know it can be difficult, so many different sources, but I really think we're going to miss an opportunity here if we can't by December be able to specifically use data that, you know, any segment, whether it's hospitals or EMS or nursing homes, can't look at and say, yeah, that feels right. And as we present to the governor in December, I think if we can't really nail down our data accurately, simply and accurately and comprehensively, I think it's going to be hard to then offer a whole lot of solutions if we don't know what we absolutely need, I think, a single source of data, you know, or multiple reliable sources of data as it relates to that. We were looking at the Georgia Center for Nursing Excellence. You know, one of the things that they show, again, just another source, is that 57% of licensed RNs and nurse practitioners are actually working right now in Georgia. You know, so again, I know we can determine how many have an active license, but then how many are actively working, and then where are they working, and how many of those are RNs versus LPNs, and I know that's a huge lift, is getting the data right and in a format that everybody can digest. But I just personally am worried that if we move too quickly onto solutions without really fully understanding the problem, that it's not going to land like we hope it will.
And this is Sean Little, if I may add to that as well. If we're looking for folks to come and address the committee and speak to different data points, Pat Horton she's been looking at workforce solutions within the state for years. She is the GCNE CEO. She would be a fantastic speaker to come and provide some additional data points that we might need in reference to faculty shortages, specific nursing shortages.
And Sean, isn't this center, Georgia Center for Nursing Excellence, isn't that Pat's organization?
That is Pat's organization. It's still fairly new. I would say it's probably within its year of inception, but she's been working on it, like I said, for years. She's been with the Hospital Association. I forget for how long, but for quite a while. She's very well versed in the data, lives it pretty much on a day-to-day basis. And she works in partnership with the Georgia Nursing Foundation and Georgia Nurses Association, which also have a lot of background on some of the topics we've been talking about today, like workforce violence, mental health resiliency, so on and so forth.
I don't know how we get the data, but I think the other thing we haven't talked about is, and we talked about how to train people into the pipeline, but at the end of the day, it comes down to dollars and cents, and how, as a healthcare system in Georgia, we sustain the current model. I think if you talk to any nursing home administrator, hospital administrator, who really works under capitation, if you will, however you look at it, whether it's contracts from Medicaid, Medicare, private insurers, you can't really adjust your price or your reimbursement based on expense. And I think if you talk to any of those people, we mentioned travel nursing, but the thing that's killing healthcare in Georgia right now are agencies. If you talk to any of those guys, if you talk to Piedmont, Athens Regional, or any of the nursing home administrators around us or Northeast Georgia, they're staffing with agency because all these people are leaving permanent employment to work for agencies because they have flexible schedules. They can pick shifts whenever they want. And the facilities are having to pay agencies double what they pay or more for positions. I don't know how we get a handle on that, but if the system can't sustain what we're paying right now, so I don't know how we get, even if we train the people, how do we get them into the settings if, I mean, because we're a capitated system, whether it's home health or hospice or nursing homes or hospitals. They're not going to get more for somebody admitted to the hospital with pneumonia. But if, you know, I've had people share with me, for instance, if a facility pays a certified nurse aide $18 an hour and the agency is charging $40 an hour for that same position, I mean, it's just unsustainable. And I think hospitals are taking the same hit. So are home health, hospice. I mean, pretty much anybody that's hiring a nurse or an aide is paying that, and they're still charging overtime. They're still charging incentive pay. So, you know, for a nurse, an LPN position, for instance, in a nursing home that may make 20 something, $30 an hour, they're paying agencies $67 an hour for that position, and that's not sustainable. So I don't know how, if that's something we even can address, but if we train the people, but the facilities can't afford to pay the demanded price, we still haven't made any
Yeah,
headway.
I think you just made an important point, is to keep, you know, keep that in mind of what can the commission address really. I mean, we've talked about not boiling the ocean. I know what the governor expects from us in terms of a final set of recommendations. And we may need to take it in chunks, you know, and Scott and I had a good conversation about this, but if this is what are the things that are out there today that we know that we can, from a state perspective, right? Like we're not suddenly going to probably regulate what contract nurses can be paid. I don't see that as a recommendation that would be something that we could go after.
We'd be okay with it.
You'd be okay with it. I'm not sure that's a position the state would necessarily take. Although during COVID, it might have been helpful for the state. But trying to keep that in mind when we do our work as well. And I don't know, right? And there's no idea off the table, but I think, I don't know. I mean, I think certainly.
What if we focus on that? There are a lot of our nurses that go to do agency, but still live here in Georgia.
Sorry, I'm sorry. Say it again.
I was trying not to giggle. So there are a lot of there are a lot of our nurses that decide to go and do agency nurses, but they never leave the state. You know, what if that's a focused or concerted effort that we as a state make? We want to keep our nurses and preserve our nurses from going into agency. Of course, we would need data to see how many that is, but there are a lot that choose to do agency, but still have the opportunity to stay home. So maybe that's a smaller focus that we can do for the state of Georgia. What kind of concerted efforts can we make for our Georgia nurses to not do agency and still live here, but stay here? And we, you know, can cut the cost that way. I don't know what that looks like or how we tackle that, and we would have to see what those numbers look like. The only other option, which is boiling the ocean, is to go after the agencies and cap their price, because that's what they're doing, right? The nurses pay as high, yes, but the agencies have really monopolized off of COVID during this time, increasing their fees and what they are receiving. And so some hospitals have tried to contract with them where they take a lesser fee, but that's certainly boiling the ocean. Don't know if that's something we could do, but you know, if we wanted to make a concerted effort on those that we know are our nurses that live here in the state that are choosing to do agency and continue to work here, can we focus on them? And I guess I was hopeful that we were going to come up with some sustainable kinds of solutions to get more people in the pipeline, but also to keep them in the state with, I mean, I hate to throw out solutions because I know we're not there yet, but with types of tuition reimbursement where you have to work in certain places and certain levels of care to work it off. Tax credits come up a lot for these health professions that we're talking about. So, I just agree that it's not just producing them in the state, but it's keeping them in the state is where the real solution, in my opinion, is going to come.
How much success do you know? I mean, I actually did the State Medical Education Board scholarship and went to Mercer. And our mission was to be in small areas but I wonder what the data shows as far as people who get those scholarships, like how many of those people finish their career in underserved areas, and how many of those people go there for the 4 years or whatever it is and leave. And Dr. Sumner, I'm sure, has some.
Well, I can tell you that when I applied for my scholarship part, they told me I'd never end up in a small town. So since I spent my life in a small town, I'll talk about it. The Physician Workforce Board, and Dr. Boki can address this. I think they gave up the scholarships. The Country Doctor Loan Program
It's gone.
It's gone because they had a few that had to work out, but it didn't work. I mean, hospital systems would pay even for trouble damages. People would buy them out, and they just didn't end up there.
Okay.
What they do now is they pay off post-graduation. So you get out of residency and go to a small town, they'll give you a fee for a certain number of years. And I think Scott's probably still on the call, but it's if you stay a certain number of years, you're going to probably stay. There are two things in medical school. It's where you grew up and your experience in medical school, a positive experience in a rural area. And those two things across the country are the most predictive of where you will end up. And they need to see good doctors like you and Dr. Boki. Though Commerce was a small town when you went there, right?
Oh, yeah.
Yeah, I thought so. But if they see a good doctor who's meaningful to their community, they're much more likely to stay there.
There's a difference between, and you started to touch on this, Dr. Sumner, but a difference between a forgivable loan and loan cancellation. So the state has done a number of forgivable loans over the course of the last 20 years for both nursing professions, for doctors to teach in rural areas. There's currently one for engineers, also at Mercer, and a number of other programs where the state invests in you and provides you with the student loan to go get your education in a certain field. And by virtue of staying in the field, working the state forgives a portion of that loan annually thereafter. There's another model, which is loan cancellation. Instead of us investing in your education upfront, which is not always a concern, it can be, but there are a lot of options for student loans, especially in health professions. Go to school, get your degree, get a job, do what the state wants you to do, which may be work in a geographically area that has a shortage or some other thing, and then the state pays it off for you. So it's a difference of how the financing works. The state currently has one of those that I'm aware of for large animal veterinarians. It's very limited and finite pool of money and slots annually, but you go become a large animal vet, work in a shortage area, and then the state pays your loans off for you. So there are different models of that. Loan forgiveness programs, by and large, are not very successful. There is a state performance review of those from the state agency that administers those. And most of the data suggests that students take those loans out because they're often more advantageous than other student loans that they can get, either lower interest rates or better repayment rates, even if they don't complete their degree. And even when they do finish, many of them go on to do something else or in a different area and just end up paying cash or never pay back at all. And so there's not a ton of data. Brian knows this as well as I do. I don't think there's a lot of data to support. And the state used to offer them for nurse faculty and faculty educators to recruit more clinicians to go into the teaching side of the healthcare industry. And they were widely popular, on the front end, but I don't know that the data supported that they were very successful on the outcomes end. And we'll go back and pull some of that data and some of those reports and take another look. Personally, I'm much more a fan of the second kind, where we don't tie up the state resources on the front end, but if you do the intended behavior, then we pay your loan off for you on the back end. It's just my 2 cents, but we can pull that data.
So Scott Bulkey here to respond. Yes, we've done away with the scholarship. There's a lot of issues there, but now we have it's $25,000 a year for 4 years if you go to underserved area, which is the definition is 50,000 or less in the county. And that includes not only physicians, but nurses, PAs, nurse practitioners at other rates. So it's there. You'd be surprised how many people don't know that is available to go there. And lastly, I would say, in addition to being from a rural area and some of that stuff, the most important thing is the spouse. The spouse will determine 9 out of 10 times if you go to that rural area. So just to throw that out there, that's very, very important.
This is Sean Little. Is there any way where we can get just an outline of programs that are already available from a financial component, just so that when we are looking at recommendations, we can either expand out what is already there, or, at least we'll have a foundational understanding of everything that is currently available. And as you've stated, there were some things that didn't really show good outcomes in the past. Is there a way to just kind of get a brief outline of those things available for us?
Yeah, we can work to put something together.
Okay, and then my next question is in reference to the schools that are available. What would be the best way for us to look at which schools have access to which types of funding support or allocations in reference to not technical schools, but
I know where you're going, Sean.
Okay, thank you.
I think so. Most of the programs that I'm aware of in the state are either administered through the Healthcare Workforce Board or through the Georgia Student Finance Commission. And so each of them have a loan cancellation programs are a little bit different. They're a little less restrictive on where you went to school, because we're not paying for kids to go to school in those. We're paying for the professional then to do the service that we want in the state. But we can pull together those, and then the remainder of the programs in Georgia are probably still at the Georgia Student Finance Commission. We can double check and make sure there aren't any others embedded at some other agency. But those are largely, Sean, to your point, to HOPE eligible institutions, public USG, public TCSG, are private nonprofit, and a few other independent institutions.
Okay, thank you.
And most of that, I'll go ahead and throw in, Sean, and you probably already know this. Most of that is statutory, but that's something that we could certainly take a look at. But that goes down a rabbit hole quickly.
No, absolutely. I was just thinking of it from a solution standpoint, because finance is a huge reason. And so when you're looking at trying to create a pipeline for your workforce, you want to make sure that, students are able to go to school, be successful in school. And of course, I'm speaking of nursing education because that is my expertise, and nursing school is challenging. So is med school, of course. It's hard to, get those non-traditional students that are willing to become nurses and enter the workforce, but when they have life responsibilities, have to work 40 hours a week and try to go to nursing school. That can be very challenging. And so I was just looking at what type of resources from a solution standpoint where we can entice students, potential students, to come into the pipeline. And I'm sure the same is for physicians as well.
Other thoughts? I mean, I think I've certainly taken some notes. I know our team has taken some notes on some takeaways and some other data sources to take a look at. Maybe some potential folks to invite to our next meeting as an open forum. Certainly feel free, obviously, commission members, to engage with us afterwards if you have other thoughts or other folks that you'd like to hear from. Brian, thanks for tackling this and sharing the data with us today. Certainly the public that's watching, we will post some information on our website, but to anyone that is interested, association, institutions, providers, individuals, whomever, certainly we'll invite folks to submit interest in being present. We'll take public testimony and information from folks in person, probably not remotely, although we'll still stream it remotely, or in writing in advance of the next commission members, and share anything that we receive with the commission members. And we'll work to filter through those and determine how much time we have for each of those presentations, if we need one meeting or two, or if there's a better way to slice those. But looking forward to assimilating all the information from each of you that have already filled out your surveys with us on the back end, and then completed your interviews with us, so we can get some of this more qualitative insights from you, so that we can start to build the whole landscape together. But not easy work, certainly, and a very short amount of time to do it. I think today just highlights that of how vast this problem is, and how nuanced it can also be, and the importance of defining the challenge as we then start to think about what solutions could look like for those different segments. So closing thoughts, final thoughts from anybody? I'll turn it back over to Sean.
Any closing thoughts, comments? You guys have been awesome today. This was a very, very good dialogue. Very exciting to hear your feedback and your insights. So, I'll be in touch. And I hope you all have a very fantastic evening. Thank you.